All right, we are in this video are going to be discussing chronic kidney injury and what all that entails. So chronic we know is bad. That means that it is progressive and irreversible loss of kidney function. Also better known as the silent killer. So this definitely occurs over a longer period of time, and the goals would just be to preserve as much of the person's kidney function as possible and prevent cardiovascular diseases by implementing and administrating the uses of the ACEs and ARBs medication and beta blockers. So some of the causes can be untreated acute kidney injury, diabetes, mellitus, hypertension, any family history, and especially those with the background or nationalities of Native Americans, Hispanics, and African Americans. Also just reoccurrent infections and autoimmune disorders, and then older adults. So this is causing metabolic acidosis. Excuse me. Some of those medications we're going to see are going to be that sodium bicarb, because of that higher potassium, that hyperkalemia, we're going to have insulin and dextrose, calcium gluconate, and Kalaxate, that per-timer medication. There are 5 different stages of chronic kidney disease. So each stage is based on that GFR rate. So as chronic kidney disease worsens, the GFR decreases. So we want that GFR at a higher level. So we know that if that chronic kidney disease is worsening, that GFR number is decreasing, and that is not good. But unfortunately, that is what happens, and we're not able to fix chronic kidney disease, as we know that is progressive and irreversible. So the first stage is typically at 90 GFR or above. The second stage is about 60 to 89. And then stage 3 is broken up into A and B. So stage 3A is 45 to 59. Stage 3B is 30 to 44. Stage 4 is 15 to 29. And then stage 5 is less than 15. And so stage 5 is ultimately the very last worst stage. That is your end stage renal disease. You're going to be needing to direct these patients that between stage 4 and definitely 5, dialysis is most likely going to be needed. Some of the signs and symptoms for this, especially almost every body system is negatively affected, especially in the end stages of chronic kidney disease. So we'll talk a little bit about each of the stages of the body systems. So the urinary system, we're going to have that oligurgic stage, that 400 mLs or less a day. And then we're also going to be having this anuria. And anuria is less than 100 mLs per day. So this is much worse than oligurgic stage. And a good way to remember that is that anuria A is before O in the alphabet. So we know that anuria is much worse than oligurgic stage. And that can be a major indicator that this has getting progressively worse. Also, for brain-wise, neurologic, we can see lethargy, confusion, seizure, and comas. For the heart, we can see hypertension, dysrhythmias, fluid volume excess, heart failure, JVD, the distension of that jugular vein. For organs wise, within our GI system, we can see anorexia, nausea, vomiting, uremic factor, which that uremic factor is that ammonia breath. And then there also could have a metallic taste. For immune, they're going to have an impaired immune system and inflammatory response. We talked about the risk for anemias within the acute kidney injury, about how that erythropoietin helps make those red blood cells. And so when we have a decrease in that, that doesn't cause the red blood cells to be formed. So that's what's causing that anemia. Also can have a risk for bleeding, and then also prolonged bleeding time. So that's going to cause an issue with our clotting. For reproductive wise, for women, they could have some amenorrhea, which would be that absence of menstrual period. For men, they could have some erectile dysfunction, some ED, and then just lower sex drive. If we're talking about bone and skeletal wise, they could have some osteoporosis, and we would need to give them maybe some Tums to bind that phosphate, and then also some vitamin D. For skin, they could have pruritus, which is that fancy word for itching, and ecchymosis, which is that bruising, and then uremic frost, which uremic frost is very itchy, and it can be all over the body. Typically, these CKD patients have this on their arm rather than just all over their body, but it can just be on their body, and it causes itching. Respiratory-wise, they can have crackles, pulmonary edema due to that fluid volume overload. They can have manifestations of waste buildup with the lack of urine output, which is that uremia, which we talked about, and that azotemia. And azotemia is elevated levels of urea and nitrogen compounds in the blood. So like we said, that this is the buildup of those waste products due to that low urine output. And then muscle wise, these patients may present with cramps, muscle twitching, especially the muscle twitching because of that hypokalemia. Weakness, osteoporosis, which we talked about. Maybe they might need some Tums, those phosphate binders. Those, because they're going to be on those Tums, which is a phosphate binder, because that phosphate level in CKD is going to be high, as well as the bun, creatinine, potassium, like we talked about with the acute kidney injury, and that magnesium and the calcium. So all of the same labs as in acute kidney injury we're going to be seeing. And just know that Tums is a phosphate binder, so it helps get that phosphate to be lower. The creatinine level where we want to see, which is our major lab in these kidney diseases, is about 0.6 to 1.2. That's our normal. So when we're thinking about anything over 1.2, 1.3, we think bad kidney. Some treatment issues would be dialysis. Also maybe a kidney transplant if they are a candidate. Typically that's because less than 60, they have to be at least 60 GFR for 3 months time to be diagnosed as chronic kidney disease. So remember that. We know that less than 60 is stage 3. So stage 3. So when we're thinking about these GFRs, we know that this starts with 90 at stage 1. Stage 2 is that 60 to 89. And then stage 3 starts that 45, between 45 and 30. So these patients have to have less than 60 for a consecutive 3 months to actually get a diagnosis of chronic kidney disease. And so we know that this can be very progressive and irreversible loss. So by the time that these patients start getting the therapy and an actual diagnosis, this can progress quite fast. But the 2 major risk factors that we need to remember are diabetes mellitus, especially type 2, and that hypertension. So some diagnostics that we can do, again, is checking that GFR level, because we know to get a diagnosis, we have to have that below 60 for 3 consecutive months. We need to be checking that BUN, that creatinine, and then your H&H, and then that potassium level. Also, another big risk factor would be alcoholism as well. And then we know that with an acute kidney injury that is reversible, but sometimes it can progress to chronic kidney disease. So that can also be a risk factor, is just having AKI or maybe a previous AKI, which has now put that patient at more of a risk for chronic later on. Some complications of chronic kidney disease would be metabolic acidosis, as we know, increased respiration rates. Your ABGs are going to show that metabolic acidosis. So the treatment for that would be bicarbonate sodium, IV. Some other complications would be infections, a higher risk for infections, as we know that immune system that we talked about with that immune system that is going to be impaired, and we're going to have an inflammatory response, an impaired inflammatory response. Kidney stones, and any type of electrolyte imbalances. We're also going to have that mineral bone disease. We're going to have that risk for osteoporosis, which we talked about. So they're going to need that calcium, either maybe from Tums, which can give you some calcium, maybe just a good calcium vitamin. supplement. And that Tums is that phosphate binder, and that's going to help lower that down as well. You can also have a medication called Renavella, and then also maybe a vitamin D supplement. For the anemia, we would want to give iron supplements, and the go-to that we typically give is ferrous sulfate, or we can do EPO, that erythropoietin. For the hypertension, we can do beta blockers, ACEs, and ARBs. And just keeping in mind and remembering that ACE inhibitors, those prills, can cause a cough and angioedema. So we need to be watching out for that. And then the hyperkalemia, we want to give that calcium gluconate, acute insulin, dextrose, and then also we can do some Lasix to help with that, diuretics and K-lactate as well. So what are our treatment goals? Well, we talked about dialysis or possible kidney transplant if that patient is a candidate. So our treatment goals in general, because we know that we're either going to have that oliguria, which is that 400 mLs per day, or that anuria, which is less than 100 mLs. So we might need to restrict some fluid because of that, because we are not eliminating as much out of our output. We also probably need to be restricting some potassium and phosphate. And we want to prevent further progression, prevent complications. The nursing process, we want to look at that personal history as well as family history. The ethnicity would be African American, Hispanic, Native, and definitely a higher risk to monitor that intake and output, daily weight, and labs. Education, making sure that they are compliant with that. Diet is very important, and especially with signs and symptoms of acute exacerbations. They need to be doing daily blood pressures at home because of that hypertension is such a big risk factor as well. But definitely need to be monitoring that, especially as one of our interventions and treatments is for those beta blockers and ACEs and ARBs. So they need to be checking, do they need an increase in those medications or maybe a change in one of them? The goals, again, we said to prevent any further complications and prevent any further damage to the kidneys. So how can we manage the correction of extracellular fluid volume overload or deficit? So this would be your dialysis or kidney transplant. And then also we can do some Lasix as well. Some nutritional therapy measures, obviously to lower those potassium. So we want to instruct eating a low potassium diet. Let me see if I have anything else in my notes. Okay, let's see here. I think that's it.